Hi, everyone. Welcome to our webinar today, the CMS Final Rule Lessons and What's Ahead. My name is Ngan MacDonald. I am VP of Healthcare Business Solutions at HealthLX. HealthLX is an emerging healthcare software company that is focused on solving clinical interoperability for providers and payers. We grew out of our sister company, Tesh Global, which has a lot of experience in the data management space. And so together we're working to solve the data liquidity problem in healthcare. I'm really excited today to be joined by two panelists. So Khoa Nguyen is an independent consultant who helps healthcare companies with their data strategy and planning for these federal interoperability and data sharing requirements. And then also joined by Mike Boeder, who is executive director for health plan operations for Children's Community Health Plan. Children's is a nonprofit HMO organization that currently serves 170 plus members in the state of Wisconsin. So welcome. And today we're going to talk a little bit about the lessons learned with the CMS 9115F rule, which basically stated that payers had to make available in FHIR API format their patients' data. And so CCHP has gone through that process, and Khoa has also managed and helped a lot of health plans through that process as well. So we'll talk about some of the lessons learned. And we'll also talk about CCHPs, like where the wins and losses have been. And then, I'm gonna ask Khoa to spend a little time and talk about what's ahead in the future. So with that, I'm gonna dive into some questions that I had. I'm gonna start out with you, Mike, and basically say, hey, the CMS interoperability final rules kind of put a lot of pressure, I think, on payers to be collaborative and transparent and patient-centered. And so I was wondering if you can walk through what your organization went through in terms of trying to meet those mandates.
Sure. Thanks, Nan. Nan, you mentioned we have 170 members. I think you meant to say 170,000.
Yes, I'm sorry.
Just a few more than 170.
But a few more, yes.
Yeah. So a little context, as Nan mentioned, our plan, Children's Community Health Plan, we have about 65% of our population are pediatrics, and about 35% are adults, and a variety of products, mostly in Medicaid, but we're also in Marketplace, and then we have a inpatient health plan product for kids in foster care. So it provides us a good mix, and we're roughly the second largest Medicaid health plan in the state of Wisconsin for context for others. So for us, a couple of things come to mind. I would say in earnest, we really began to begin our interoperability journey probably in the fall of 2019. So pre-pandemic. We're a very active member of our national association, our trade association. So that's the ACAP, Association for Community Affiliated Plans. And we were at the fall conference and had the opportunity to hear some speakers get more in depth into what was happening with the rule right around the time the rule had been finalized by CMS. And candidly, while we had heard of it previously, had tacitly paid attention to it, what we certainly didn't really appreciate or understand, the implications of the rule at that time. So, what we learned, I think, one of the key takeaways I had from that conference is I was there with our finance director, is that we weren't ready, and we needed to get prepared, but also do that in the way that made sense for us as a business and go through our decision-making process. So for us, as I mentioned, ACAP was really the source of truth or a great resource for us from the beginning. And from there, we began to leverage all of the various resources we could to better understand the rule and ultimately establish a decision-making matrix or process for us, which is pretty congruent with our normal decision-making process when we get into large projects. And from that, we began to work and get to know Khoa particularly better. And he has been an outstanding colleague and support for us in this process as well. So ACAP connected with Khoa as well for his expertise and helped facilitated a lot of interesting conversations that led us to where we are today. So what do we do? Really, we realized after we started doing some research again that we didn't know enough, that we did not have in-house expertise either at our health plan at CCHP, nor through our parent. We are owned by Children's Wisconsin, and we have a shared service matrix for a number of administrative services, including IT, compliance, and legal as an example. And that it was up to us to create that better understanding. And so with that, we established a steering committee in Q1 of 2020 and formally engaged Khoa then as a consultant as well, and continue to work very closely with ACAP, joining the affinity group specifically around interoperability, and developed a strategy and created a very comprehensive work plan. And it led to a very tight and well thought out RFP, which ultimately we launched in roughly the mid to late Q3 or so of 2020. And we're able to execute, go through that decision-making process and execute a contract in time to launch in the beginning of the year. Our goal was October of 2020. To have that up and running, and we were able to do that November approximately with HealthLX and TG, and began our implementation process to position us to be prepared for the 7/1/21 enrollment timeline.
Khoa, do you want to add anything about other plans and what their journey kind of looked like?
Yeah, thanks, Ngan. Maybe for a little bit of context, my history, working with, previously working for the health plan of San Mateo, and then working for ACAP. Again, ACAP represents a lot of plans similar to Mike's plan. Children's Community Health Plan is, they're mid to small size plans, so probably a few 100,000 lives, some even less than 100,000 lives. Most of them are regionally based, maybe statewide, but primarily local. So what that usually means also is it's typically small IT shops and staff. So, what we did early on with ACAP is to do a lot of education and early planning. We did a virtual conference, a vendor showcase, just to understand the market, who's out there, what kind of solutions are available, and then kind of go through a planning collaborative. Initially, that was with 17 ACAP plans. Again, Mike's plan was part of that. And then recently, at the beginning of this year, we're in the process of doing an implementation collaborative. That's with 23 ACAP plans. So this is a little bit of the context where I'm coming from. I help lead a collaborative with 23 ACAP plans and 13 California plans. And just from a recent survey of those plans of who's live relative to July 1, you pretty much are seeing, not surprisingly, kind of like a bell curve where you have two extremes. You have a really small handful, less than 5, that are live, that went live July 1. And then you have a few that really just got started with a vendor solution just prior to July. So it's probably going to take probably 6 months. And then the vast majority is either they worked hard towards July, but most of them didn't hit it. So they're really more late July, August timeframe. That's kind of where Mike's plan is. And then the other sort of half is they still have a lot to do. And they're probably going to be more early fall. So like the September, October timeframe. I think many of the lessons that sort of gets represented, at least in these small to mid-sized plans, is, some plans plan really early, like Mike's plan, even that, and it was hard to hit July 1. So going through a process, understanding the vendor. I think this one was a little bit complex because of the regulation, that's 500 pages, but it really involves 3 parts. And it's a little atypical the way a lot of our health plans kind of operate. When we look at regulations, you have to rely on compliance, but this is a very technical regulation. And in a lot of compliance, this is difficult to understand. And then also CIOs and IT, they might understand the technical piece, but they really don't understand a lot of the policy components. And then also from a vendor perspective, you can't rely solely on vendors, because this is a pretty detailed, and each plan kind of is impacted a little differently. In Mike's case, they're an exchange plan, they have a prepaid inpatient plan, and they have Medicaid plan. So it involves really a lot of different pieces to understand the regulation. So that takes time, understanding the marketplace and vendor. Most of I think the ACAP safety net plans rely heavily on the vendor. Very few were building it internally. Some of the bigger plans, like Geisinger, LA Care, some of the big ones, but most, again, are mid to small size, and they're heavily dependent on the vendor. So I think maybe some of the things that I've seen so far are but causing delays. And love to hear Mike, some of the things that kind of cause some of the hiccups with you is plans are just overwhelmed. There's a lot of stuff happening. Vendors are overwhelmed. I'm hearing from health plans, they can't get in contact with some of their vendors. I'm sure that's not HealthLX's case, but some of the other vendors, I'm seeing communications that got unanswered 1 to 2 weeks. Even notices from vendors saying it's going to take 1 to 2 weeks you're in the queue. There's just a lot going on. I think the other is just, the advice I give a lot of plans, and what I'm seeing is there's actually no need to rush. I think everyone's trying to hit July, but CMS and states are kind of taking a relaxed approach to the deadline, as long as plans are making a good faith effort, working towards progress, and have a plan in place. I don't think it's, there's no direct monetary penalty, so that as long as plans are working towards it, I think that's sort of the best course of action. And I think most of the plans are going to be in this July, August, September kind of window.
Yeah, I think our experience, and especially with CCHP and others, is that it's really truly a collaboration between the vendor and the plan, because hopefully your vendor really understands the regulations, has a great partner like you, Khoa, to understand, like the details of that. And then the health plan itself is the one that knows its data and where it lives. We found that there is a struggle sometimes with kind of putting the thought processes around a data, like relational database mind frame, and the way that FHIR structures its data resources. And that's a little bit of education on the part of the health plan. But that's all entirely doable. And when we come in, we usually tell people, hey, let's look at what we need to do, and then let's put a plan together so that you can actually say, like, this is where we're at, and this is where we need to head. So kind of turning back to you, Mike, as you walk through and look back upon like the last few months, what are some lessons learned that you would take from that, for others kind of in your position?
Well, there's always lessons learned, right? I mean, there's always opportunities to say, well, we could have done something a little bit different. And at knock on wood, thus far, I feel really good about what we have done as a process. So one thing is, like, all of the plans understand, like, what is your business decision-making process? We all have a culture, we all have ways in which we make decisions and work. And so for something like this, and I think, Khoa was certainly touching upon it, it's very complex and it's new. And it's hard to know, like, who is supposed to lead this or be in charge of it. And it might be different depending on your business structure. For us, as I mentioned, we have a shared service environment. And so compliance and legal, as an example, are through our parent. And we are all one. We are all children's as it relates to consolidated financials and mission and vision. And yet, the reality is when we think about our business, we're a part of Children's Wisconsin, a nationally recognized healthcare system, top 5, and ultimately, been around 125 plus years. As a plan, we've been around 15 years, a little bit over 15. So we're, very young in our existence, and yet we're now a little over 30% of the overall organization's business. And so what we've learned, and this is not unique to many provider-owned plans, is that some of the internal health plan needs, you have to build those out. They're not there in existence previously because the system has been designed to support the provider side of the business. And so fortunately, we have a very collaborative organization. And so what I knew right away is that we needed to develop and have a comprehensive, well-organized steering committee that was inclusive of all of those key stakeholders internally to help us understand what are our needs. And ultimately, again, this is where we were able to leverage the ACAP resource and work with Khoa to help us facilitate that process early. So that was absolutely very smart for us, because ultimately there's no way we'd be even remotely close to do this from an implementation standpoint or at implementation now, if we hadn't done that much earlier in the game. So we knew that going in. I knew that once we realized we did not have that internal expertise, we know our history, we know our decision-making process, it required us to get disciplined in understanding the rules and regulations, number one, which is ongoing. Identify that business strategy. So that is the factors of provider-owned plan, some of those administrative services, IMS, corporate compliance, legal, and the fact that we partner with two different TPAs or third-party administrators to help our claims and customer services. So fortunately, we are a business that is used to partnering, because that's how we had to grow and build. Because of that, all of that resource wasn't necessarily there. So we have experience with that. We partner with a lot of different vendors, do a lot of negotiations and conversations, and that helped us lead to that RFP process, which was critical. And we built in our discovery within our RFP with a goal of having vendors having the best ability to understand us, so that when it came to choosing the vendor, that we wanted no surprises. And that is exactly, I think, by and large, what happened when we made our decision with HealthLX and TESH Global. And as you said, Ngan, and we talked about this internally, once we've gotten to that decision, it's truly a partnership. We have to see each other as partners. We don't talk about our vendors as just vendors. They have to be partners. And we have to act that way, and we set up our decision making that way. So that has all been very successful. The reality is a couple of areas that have been struggles for us do speak to our shared service environment. So these are business decisions that have strategic implications beyond the health plan. Things like, where's the hosting environment going to land? Who's going to own that? Is it going to be our IMS team? Are we ready to do that, or do we start off with our partners with in this case with TESH? Certainly the contracting process I knew would be complicated, because we have a lot of experience negotiating contracts, and that is in part because with HealthLX and TESH Global, those are two organizations that we chose to engage with both of them. So it just is added moving parts. But we built that into the time frame because we knew that would be part of it. We engaged in partnership in good faith, and it has been very successful. We're very pleased with where we're at. And I think for us, we would definitely not have been here without ACAP, without Khoa, and now without, we feel like, with choosing the right vendor partner with HealthLX and TESH Global.
So thanks, Mike. Khoa, I know you've worked with a number of health plans. As you reflect back upon their journey, can you talk a little bit about what they could have done differently, and why some of them took so long to be able to comply?
Yeah, I think a couple of things come to mind, and kind of Mike touched on it, is people's sense of like what early means in the planning process is always somehow limited to 6 to 9 months. But when you actually put it on paper and you work through with a plan, you realize just understanding your vendors, typically a lot of the safety net health plans, at least, they go through an RFP, an open RFP process. And if you don't understand the market, what vendors are even out there, that takes time. That can take anywhere to 3 to 6 months. And then you go through a contracting phase. That could take 3 months. People think it's 4 weeks, but then when you go through the process, it takes a couple of months. And then implementation, 6 months is really probably safe, but for whatever reason, a lot of plans love to put down 3 to 4 months because that's what a lot of vendors promise them. So there is a lot of hope that you can get it in 6 to 9 months, but really, if you play it out, even in Mike's case, who did it really early, probably like a year and a half, that's really the time frame that is really built into this, and most plans didn't have that. If anything, they finalized contracts really Q1 of this year, anywhere from January, even all the way through to March. So one, they were just against time. I think the other one, though, and I think to Mike's point on this, the vast majority of plans, whether they're safety or even commercial plans, fire is new, API is new, this whole regulation is new. So you have very little experience, and there's not a lot of avenues to understand that. And I think the benefit of having, at least through ACAP, a learning collaborative, both on the planning and implementation of the plans that participated. So you're not relying just on one consultant or just on your vendor. You can talk to plans who have similar makeups of how your infrastructure is set up and who's coming through some common issues. The ones that really have, I think, what they found in certain delays among plans is the data mapping. They realize it's complex. I think part of it is our plans rely heavily on other vendors for the core claim system, the way the infrastructure is set up. So you have a fire API solution vendor who has to work with a couple of other internal vendors, and everyone's got to play nice. So the vendor relationships, that becomes, a barrier to how fast things move, and your existing, architecture, infrastructure, and how that easy can be done. Plans that have, centralized data warehouses or existing, staff that have a lot of knowledge internally, not relying on vendors, so they can respond quickly. I think, like Ngan, you mentioned, if you have questions about existing data, they can respond pretty quickly. That takes time. So I think a lot of that kind of plays into it. And I think the other experience that I've seen that made things a little bit more difficult is plans who had experience with already providing claims data. So for example, through a member portal. So if they had experience transmitting claims data, even though it's not in file format, but at least making that available through a member portal. And then also related to that is going through like a member identity and authentication process, so that it's familiar enough. So when you talk to the vendor and the smart on fire requirements, you're at least a couple of steps further. So the ones who don't, and what I found is half of our safety net plans, they didn't have member portals. So again, it's all new and you're relying on vendors, and that takes time. It's a little bit of a learning process. So I'm not surprised July 1 was only hit by a few plans. I think the vast majority put all those pieces together. And then in COVID, right, and kind of in the tail end of COVID, you put all those pieces together. I think people learning that it's okay, probably July, August, September, that's probably more realistic, where most of the plans are. Only a few really went live. July, when we say live, it's up, but it's still a work in progress, right? I mean, I think the implementation guides and some of the specifications, it's still a work in progress.
Yeah, I think that was the hardest thing for us to communicate to our partners, was that as basically as we were building the airplane, the specs were still being written. And so you're trying to get this airplane to fly, and people are coming in saying, oh, well, we also want a door here. Oh, forget about it. We don't need that fire escape there. So that's been, I think, hard to have a clear, definitive timeline for people to follow, because, even, as we look ahead to what's next, there are still some final rules that came out, but are not final yet, right? So as we look at prior auth, it's like, well, there's a whole bunch of things there. Now the question is, when is it going to be finalized, and what are the timeframes for that? So kind of segueing a little bit into sort of, we know that the road for interoperability is a long road, right? We've been trying to do this since ONC was first created. So question, I'll start with you, Khoa, again, since you have so much experience in this. What should the payers be focused on now as they look forward, as you kind of, what's next?
Well, I think there's a couple ways I think plans can look at it in a little bit of a staged approach. I think the first one related to July 1 is make sure you're up and running. It's functional. Patient Access API, Provider Directory API. And I think to your point earlier, Ngan, is that it's still a work in progress. It's not that you just turn the lights off and then you just move on to the next thing. Is when it's up and functional, and then kind of take a look at how things progress with just the Patient Access API. And I think from a plan perspective, you know, if this is meant to help with member engagement, help operationally with plan operations, then we want to see our apps connecting, our members connecting, and are they utilizing it? So I think the first stage of what's next is now you put the store up. Okay, are people shopping? Are apps coming to you? Are you developing relational apps, or apps interested in coming? And I think what we're seeing so far that it's pretty quiet, but it's really both parts, both the apps and members. And it's okay if it may take time, but I think just checking to see what kind of utilization adoption there is. I think the second piece is actually then working on some of the other components that are instead of that gray area. I think our plans are still trying to figure out. I think the two main ones, one is from a financial perspective, because again, from the safety net plans, making sure that it gets represented in our rate structure and it gets funding from states. And I'm hearing from early states, Mike, you know, we can talk offline about this, but I'm hearing a couple of ACAP states plans got recognition from the state on their rates. So I think that's just from a financial perspective, you know, our plans need to keep working on that. I think the other is some operational things, like how do we deal with authorized reps? Things that we, again, from a member engagement perspective, those things are of interest to us. And how do we make sure members are aware of this process and apps are connecting to our plan so that this could be a benefit to the member? I think the third then would be the next phase, which is more strategic. Well, how can we actually take this outside of compliance now that data could be available? And that's where I think payer-to-payer comes in. And it's a January 1 start, but I think the approach, if most plans aren't going to be up and live until maybe late summer, early fall, is preparing for January 1 or soon after, and then seeing how that could be probably used, you know, a little bit more from a new enrollment perspective. That one, I think our plans would have a little bit more control over looking at continuity of care, you know, population health management, getting that information, you know, on day one and when a new member comes in. I think those three, I think the focus is still operational, getting up and running, taking a look at maybe additional opportunities outside of compliance, and then moving to the next step on the second requirement, on the peer-to-peer data exchange.
Sure. I'm going to turn to you, Mike, and ask you about like what you think is ahead, and you know, how are you guys looking at this in terms of, you know, whether or not CMS, how are they going to enforce it? You know, what's the planning that you have right now to mitigate risks in that end?
So a lot of what Khoa said obviously resonates. We understand and agree and are working towards that. I also would, you know, I don't know that I would call this advice because it's a little late for that, but there's always that thought process. And the thing I guess the thing that we talk about that makes me feel a little bit better about what we're doing here is it is really important, we think, to simplify this. This is obviously very complex, it's new. So to Khoa's first point, I mean, we have to, you know, the classic, don't let perfect be the enemy of good. I mean, we needed to get up and running. And so there's a couple of really obvious examples for that. So what our wireframe looks like, essentially how our members will access the ability to consent and so forth. We could have created something really quite, you know, complicated and yet, you know, really interesting. Chose not to do that because, yeah, we're working up against a timeline, even if that's, you know, perceived softer timeline of 7/1. You know, we wanted to get to a place to where we could keep moving because I totally think the utilization piece to this is really important for us to watch. I agree with that because, you know, transitioning into that third strategy phase, and we've had this conversation, it is a hard message to determine how we're going to market this, not just to members and other stakeholders, but even when we talk about this amongst our own staff. We talk about use cases and value. Population health as an example. How is this going to, you know, make this healthcare experience ultimately better? Some of that requires some imagination and creativity and some thought process on how exactly and what that will look like. And that's hard to drill that down into a lucid message for, let's say, our utilization management staff, our advocates that are out and about in the community. Like, what does this mean to me? We always ask that question with our, you know, with all of our staff. We want to be able to have something that they can relate to, some context, some messaging, and what is this going to mean to me and my role and the members ultimately in our business. And we're working through that. So we have some lunch and learns that we'll be planning with our teams, and we're going to be walking through what that member experience will at least visually look like very shortly here. But again, that next phase of, you know, what will this mean to quality and population health? And I think that is a yet to be known, candidly. I've sat in, listened, we've had deep conversations about what it might be, but that's theoretical at this time. So I think that's where, once we have some operational functionality, which we're there now, and we have some utilization, you want to think about ultimately, well, how will this play itself out with quality and with our medical director teams and so on and so forth. And that's a harder message to even convey right now, very candidly. What people do know is that it's new, it's complex, it's required, it's expensive, and that we have developed a process that is, you know, we're learning and gaining a better understanding of what we have to do, and then we have to get to a point to where we develop strategy on what we want to do once we're past, you know, meeting those minimum requirements. But that is the first step. So I would just suggest to anyone there, like, take a deep breath and focus on that and get up and running rather than moving right to the use case and longer term value, because that's skipping several really important fundamental steps.
Yeah, so we have a question on, you know, from our audience about any thoughts on the next set of compliance states around payer to payer and prior auth information. And kind of, I think that plays to your question around population health. And, you know, the fact is that with payer to payer, you will be able to get in clinical information from a prior payer on your members. So I don't know if, Khoa, you want to take a stab at that first question around compliance states for payer to payer and prior auth and whether that's feasible or not.
Yeah, and I'm going to draw upon, you know, a couple of sessions that I've helped facilitate with the safety net plans on sort of use case potential. And, you know, let's take the patient access API. You know, that one's a difficult one. I think Mike was alluding to it for our staff and our operations to sort of connect to, because so much of it is dependent on the third-party apps, the consumer apps, and what members do. So that's really, a lot of it is out of our control. I mean, we can do some member engagement awareness, but a lot of it is driven by the quality and availability of apps connecting to us, and then members being aware, using those apps for certain purposes, really outside of our plan control. So that may take a long time. And we know from our own history, from a lot of our plans, particularly Medicaid plans who do have member portals, you know, we'll be lucky to get 5% adoption that actually have accounts and go and looking the member portals for either their claims history or their auth history. So we already know just from that experience that it's going to be pretty limited. But I think when we've had conversations with plans, particularly with clinical leadership, they see two areas that there's potential. One is that the payer-to-payer new plan enrollment, and also the provider potentially sharing data, you know, two-way data with provider, getting clinical information and also making it easier for us to send information to providers. And I think most of our plans love to do that. We want to do that. So it's just getting the harder part is getting clinical information from providers outside of just claims data. I think that's where our two opportunities lie, in the payer-to-payer. It helps that in regulation. And again, from our discussions, if we talk directly with clinical staff, they see it as, oh, that's typically what we want to do is, get a risk score right away, put them in, if they're at high risk, put them into, care management program that's already established, identifying them, or, do continuity of care so that there's no hiccup, when they go to the pharmacy, in the same way if they continue to see their specialist, so that there's no bad experience during that initial transition. Today what happens is we have zero history on a person, even though they have, complex conditions and they've had that for many years. If they enroll in a new plan, we really have no data on them until we get a claim in the system. So I think that's definitely an opportunity if we can make sort of the technical piece work, that it already aligns with how our plans do population health management today. I know just in talking to a lot of plans, the biggest interest is that plan provider API data exchange. And some plans are and health systems are already doing that, particularly HRs who are already on fire. And that's some of the things that we're showcasing, but that's not in regulation right now. It's proposed, and that might take a long time, but I think that's probably more the use cases, as Mike was mentioning, that our plans can see as a direct benefit that we can impact, less probably on the consumer app member, and that probably just will take longer.
Do you have any kind of crystal ball as you look forward about when we might get final rules around the provider, the providers access API, the ability for payer and providers to exchange data?
My understanding is they're gonna announce soon. They're still weighing on what they're gonna do with the rule. If they open up the comment period, I believe the timing's coming up where they have to make a decision if they're gonna open it up again or just gonna rescind and take it back. One thing I forgot to mention, the provider plan API, whether it's in the rule or it's something we could do today, regardless of the rule. But if, plans, I think that's how we would value a lot of our vendor solutions and capabilities. If we look back, 2 years to say, some of the criteria we would do is, can we share and use clinical information from providers, particularly for HEDIS and risk adjustment for plans that are in the exchange and Medicare Advantage, because that's when the CFOs we know start listening when we talk about HEDIS, in addition to clinical, HEDIS and risk adjustment. And I think a lot of our plans would love that component in there, that providers could have access, because it doesn't require consumer consent the way patient access API does. It doesn't require providers to do it, but obviously I think it would enable that and push more of our plans to do it. My understanding, CMS is still weighing, and again, they're still focused on the patient access API and the existing rule and all the other things that are happening with the administration change. I'd be surprised if anything happens anytime soon. It'd be unfortunate, because I think that drives a lot of our plans to act and motivate to do things. If I had to take a guess, or the plan provider one would probably be easier to do than the prior auth. The prior auth one seems, even from a technical standpoint, the feedback we're getting is that's a long ways.
It's a lot. Yeah, it's a lot of detail to that one. Mike, you're in a unique situation, right? Because you've got CCHP, the health plan, and then you've got, Children's, which is the provider. Can you kind of give perspective on that, payer to provider API and like what you guys would do with it?
Well, I think as Khoa alluded to or stated earlier, there's a couple of things. Like mostly that's going to be about clinical management, clinical care management, and getting access to information, in a much more uniform, universal way than what we do now. I think the interesting thing as we think about that or contemplate it is all of those details about what information might be excised from what would be shared, and whether or not it will be really anything new or useful to our teams or not. There's also a candid this has really nothing to do with, our parent relationship. It's very collaborative. And candidly, we also have a very different provider-owned model. We don't need our provider does our parent doesn't need us to try to promote business for them. They already have the market on kids, and that's not the reason we got involved in the beginning to begin with. Very mission driven. And so I think, I know that's not the case in other circumstances. So we're fortunate in that regard. So the truth is like, there's also a lot of concern about somehow this is going to provide access to providers, that is, have access to information that's going to like give away like what costs are, rates, or somehow that gets like woven into this conversation erroneously. But I hear that, and I hear those concerns, and that's where the compliance teams get involved. We don't experience that. And frankly, it's NA anyhow with price transparency very, very soon. So that's a different conversation for a different day. But, having that information in theory, in that uniform way to our clinical teams will absolutely position us to do a better job with population health, as Khoa alluded to. So I think he's right. That's a great way for us to position, how this could be, an immediate benefit for our members through our care management programs that we are already doing, where we could get access to information much earlier to engage those members, which has proven to be very effective and member friendly, meaning our members enjoy and appreciate it once we're able to engage with them.
So we have one more question talking about the fact that the penalties aren't clear from CMS about, what's going to happen if I don't make the enforcement dates. And so the question is, what should payers be prepared for? I don't know if that's a question you can take, Khoa, and sort of speculate on what you think might be some of the penalties that come out of this.
Yeah, that's probably the most common question. As plans were, this is probably what I've been spending the last month or so on, as plans became, as they approached July, they realizing they're not going to hit July. And so it's like, oh my God, what's going to happen? But also, what do I tell my CEO? And I think the response I would give here is, it depends on your product a little bit from a purely compliance standpoint. If you're a Medicaid plan, it's dictated by your state Medicaid agency. They're the ones who are responsible for enforcement, and CMS is very clear on this. So in Medicaid, it's the states. For Medicare Advantage, it's CMS, and QHPs in the marketplace, it's CMS as well. But it's been pretty clear that even though they've officially said July 1, how they've interacted both with states and payers is the most important thing is plans are making a good faith effort, that they're working towards progress, and they have a plan in place, and they can justify why they reached the dates that they have or why they haven't. And again, because a lot of this is dependent on external entities like vendors and other issues. Again, COVID kind of being a big factor in a lot of timelines this year. So I think the most important thing is less about what the penalty is, because there's nothing clear on that, is talking with your state, if you're a Medicaid plan, talking with CMS and the marketplace on here's where you are, here's what your plan is over the next 3, 6, 9 months, and being very clear and working towards those things. I can say though, just in one thing I mentioned, plans are relative to a lot of the safety net plans, but most states didn't hit July 1 either. 2/3 of states were not ready for July 1. Even the 1/3, again, it's July/August, July-August timeframe. So states weren't even ready. States that had Medicaid fee-for-service, they had the same requirement. So obviously states who have to enforce against Medicaid managed care plans, there's a pretty common understanding is as long as you're working towards it, I tell plans worry less about the compliance and penalty component and worry more about making sure you're making progress. If you make no progress in 2 months, states and CMS, they're going to care more about that than hitting a July or August timeframe. So until they say anything, I know a lot of compliance, sometimes that kind of gets them going when you give them a penalty sticker. But in this case, it's more of just the vast majority of plans are going to be July, August, September So as long as you're working in that time frame, I think you're going to be pretty safe.
Yeah, and I think the other thing that we often tell people is, think of this as a hockey stick. Initially, the demand is going to be very low, and applications are just going to probably hit the larger plans in order to connect. But all of a sudden, people are going to start to realize the value, and more will, will start to adopt this. And then you have to be ready to support all these third-party vendors, and so you should have your processes in place. At first to address the onesies and twosies, right? But then what about this whole onslaught? So we don't have any more questions coming in from the audience. And I could talk about this forever, but I recognize you guys' time is valuable. So I just wanted to see if any final words of wisdom you have, Mike or Khoa, before I thank our audience and end the webinar.
Mike?
Trust your resources and your business processes is what I would suggest. And ultimately, Khoa said this earlier, or alluded to it essentially. So if you're planning on 6 to 9 months, my very tangible exception or recommendation is take that and add at least 25% to it. Think about this perhaps as a home remodeling project or building a house or something along those lines. An X factor is always present. It will come up. It's brand new, as Ngan and you had stated. I mean, these things are literally changing as we're working towards timelines. So, that can get really frustrating, confusing, and overwhelming. So you cannot boil that ocean in a day. Don't try. Build a little flex into your process. Focus on the things that you need to get done, and ultimately, you'll find out pretty quickly, I think, if you've got a major blocker or barrier. And that is where you do need to have a great relationship with your partner. And if you're in a best case scenario, you have some sort of outside resource as well to further help, quality check or validate and ensure that you're moving down a path that is logical and makes sense. So, and there's just no getting around. You're going to have to invest a lot of time and energy resources in this in order to at least become competent. That has been our experience.
Yeah. What about you, Khoa? Any final words of wisdom?
Well, I would say, I've been fortunate. I get a chance to work with plans and people like Mike and Children's Community Health Plan, but that's also a lot of the ACAP plans. And I think the biggest takeaway I have from this is that this interoperability work is too new and too hard, that we almost have to work collaboratively. We have to work together. Even just any plan, whether you're safety in an ACAP plan or not, is don't rely on just one resource. Don't rely on just your vendor. Don't rely on just one consultant like myself. And what I benefited from through our our collaborative programs is when you have multiple plans sharing, you have multiple consultants sharing, you have multiple vendors sharing, and to those who are out there, when you have either a consultant, a vendor, or other people that you're working with who don't want to do that, you're going to realize how limited you are, because so much of this is developing and you need as many smart people talking together and sharing. That's when we've learned the most. And you realize you don't have to be the first person to do this. Someone's probably already done or going through the same thing. There's some copy and paste you can do. You can save yourself a lot of time and money. I'm a little bit skeptical to a lot of consultants or vendors who, give a straight answer, and you realize that's not the only answer out there. We're kind of in that space. There's a lot of gray area. So, to the extent possible, whichever piece you have in the puzzle, it can be on the consultant side, on the vendor side, on the plan and solution side. The more people you can work with to figure this out, because it's an ongoing process, the better place you're going to make better decisions.
Thank you so much, Mike and Khoa, for giving us this time. For those watching, if you have any additional questions, feel free to email me at info@healthlx.com. And I want to wish everybody the best of luck as they move forward in their interoperability journey, because it definitely is a journey. Thank you.
Thank you.
Thank you.